to introduce to you Azadeh Yadalahi. Azadeh did her PhD in electrical engineering at the University of Manitoba, where she invented a home sleep apnea monitoring device. And then she had the wisdom to come and work with me as a postdoctoral fellow, and she came with very high expectations, and I'm very pleased to say that she more than lived up to them. And she completed her postdoctoral fellowship with me and actually came here to learn about human physiology, and I think some of it rubbed off on her. Am I right? Yeah. And I learned about electrical engineering, but I think she learned more than I did because she's smarter. But in any case, Azadeh has been a real whirlwind, an absolute whirling dervish of energy and creativity. Has created a dynamic team, has gotten lots of grants, and I felt she was a very good person to represent our sleep team here at Toronto Rehab. So without further ado, Azadeh, please take the stage.
Thank you so much for such a nice introduction. I'm really humble about that. And yes, I learned a lot from the team at Toronto Rehab. And thank you to all of you for coming today for this talk. And I hope that we can share what we're part of the research that we're doing at the sleep team with you and get your feedback and potentials for collaboration with all of you. So what we're trying to do is to try to improve the sleep, and as an engineer, try to engineer better sleep. So we all know that at Toronto Rehab, we have three main missions, and one of them is prevent injury. And then sleep team, what we're trying to do is try to help to prevent injury by improving the sleep and the sleep quality, because the sleep problems lead to daytime fragmentation, daytime sleepiness, and cognitive impairment among many other cardiovascular and chronic disorders that contribute to the injury and low quality of life. There are different respiratory disorders during the sleep, which are usually thought of being different. And we want to show that this is not necessarily the case. So one of the most common type of respiratory disorders during the sleep is when people have problems in their pharynx or pharyngeal airway and stop breathing during the sleep. So what you see here in the first model is a fully open airway that the air is easily go from the nose to the airways and everything is fine, and that's a normal breathing. But what happens is that during the sleep in people who either have low muscle, dilator muscles in the pharynx or lots of fat and tissue in the pharynx, because of the gravity and the weight of the muscle, the tongue is being pulled downward toward the back of the throat. And as you can see here, it causes a partial collapse of the airway. So now the amount of the air that goes through the nose or mouth to the airway is considerably reduced compared to the fully open airway. And in the very extreme cases, this part of the airway can completely collapse and block the passage of the air to the airways, and that's also very common in patients with severe sleep apnea. And these partial or complete collapses of the airway can happen from 10 times per hour to up to 100 times per hour of sleep. So they all go to these frequent collapses throughout their sleep. There are different symptoms of the sleep apnea. One of the most common that we're all familiar with is the snoring. So that's one of the most common types of breathing disorders during the sleep. And the sleep apnea has serious cardiovascular and cognitive consequences because of all these frequent collapses of the airway and the stops of or lack of oxygen to the brain. It causes 4 times more likelihood of a stroke, increased hypertension, 3 times more risk of heart disease, and it costs billions of dollars each year. So one of the main challenges with the sleep apnea that we will discuss later is how we can find better ways and more convenient ways to monitor and diagnose sleep apnea so we can treat the people sooner by knowing sooner that they have a disease. The other challenge is that about the treatment of the sleep apnea. So the most common treatment for sleep apnea is called CPAP, or continuous positive airway pressure, which is basically to wear a mask during the sleep to keep the airway open and stop collapse of the airway. But the challenge with the CPAP is up to 80% of the patients who should wear the CPAP are not compliant with their CPAP. So either they're not wearing it at all, or they're not wearing it completely throughout the sleep. And that's the other challenge of how to find better treatments or more personalized treatment for sleep apnea. The other respiratory disorder which is common in the general population is asthma. So about 10% of the population throughout all age periods have asthma. And one of the points about asthma is that it gets worsened during the sleep or when the people lie down. So they have more symptoms, more wheezing, more coughing when they lie down or throughout the sleep. And asthma is usually thought that this is a problem of the small airways in the lung. So what you can see here is a normal airway. So there is no opening. The airway lumen is pretty open and the air can easily go in and out to the alveoli. And this is an asthmatic airway when there is no asthma attack. And as you could see, it's already narrowed because of with all these foldings, and so there is a shortage in the passage of the air. What happens during an asthma attack is the smooth muscles, which are all around the airway wall, are going to get contracted and then make the airway much, much narrower to the point that they stop the breathing, so the person cannot exhale. And what they do is they give the patients bronchodilators, which what it does is basically releases these smooth muscles to try to let them to breathe. So asthma is known as a reversible airway disease in the small airways. The other type of common respiratory disorder is the chronic obstructive lung disease. It is very common in people who are smoking or in the older age. And again, it's a problem of the small airways. But unlike asthma, what you can see here is that the airway is fully changed or remodeled. So it is not reversible, or you can't use bronchodilators by definition to reverse the airway narrowing in the COPD. And chronic obstructive lung disease is going to be the third leading cause of death by 2020. So this is the general physiology, that these are three different disorders of three different parts of the lung or airway with different sort of mechanism. But this is not the whole story. When you look at really what's happening, there's growing evidence that these three disorders actually have a lot in common. There's a high overlap between them, which is beyond just a random overlap. And in most cases, if you treat one of them, like for example, if you improve sleep apnea by CPAP, the symptoms of COPD or asthma gets better. And they have common risk factors like aging, being in the supine posture, smoking, lack of activity. So one of the things that we're trying to do or show at the sleep lab is whether similar mechanisms contribute to all of these disorders by affecting both airways in the lung and in the pharynx. And that's based on the change in hemodynamics and the shift in fluid. So because of the gravity, because of spending a lot of time sitting during the day and lack of activity, what happens is that during the day, some fluid will accumulate in the interstitial space of the leg, because now we have more pressure in the vasculature in the legs. And now when lying down to sleep, there's no gravity anymore. So the whole balance of the pressure is going to change. And part of that fluid which is accumulated in the legs during the day is moving out of the legs through the vascular system and goes to the upper body, and now can get into the capillaries in the lung, in the airway, or in the pharynx. And what we have shown is that fluid accumulation in the pharynx can narrow the pharyngeal airway and increase airway or sleep apnea severity, and fluid accumulation in the lung can increase airway narrowing in asthma. So what I'm going to talk about our research based on this introduction is first about the basic physiology of what we are doing and how we are trying to investigate the role of posture and the sleep on the pathophysiology of airway narrowing during sleep. And then how we are trying to translate this research into the clinical practice or commercial devices. And we're trying to develop convenient and portable devices to assess breathing disorders during sleep, as well as developing personalized treatment for improved management of these disorders during sleep. So one of the first things that one of the works that we have done was try to develop a new device or a better device to monitor these fluid movement in different body segments so that we can really test this hypothesis. And this is based on a very nice basic physics that fluid in the body is a good conductance of electricity. So if you measure impedance of a segment or any tissue, it is inversely related to the amount of fluid in that segment. So with this system, if you try to measure impedance, say in the leg, at the bottom and the top of the leg, and know the shape of the leg in terms of the length and then the circumference of the leg, we can use this equation and then estimate the amount of fluid in the leg. And the beauty of this system is that we can measure the fluid volume in different body segments continuously. We can do it non-invasively, and this is the first system to measure the fluid in the neck. So we use this system in different studies at the sleep laboratory here, and these are the summary of what we found. We showed that overnight the fluid moves out of the legs and accumulates in the chest and neck. So although everyone knows that there is an immediate shift of fluid when you go from upright to supine, we show that actually it continues to change, and it takes about 5 hours for this fluid redistribution to get into its final steady state. We showed that the higher the increase in neck fluid volume, the more severe is a sleep apnea. And even more importantly, in people or in men who don't have a sleep apnea or have mild or moderate sleep apnea, if we fluid overload them by injecting saline during sleep, what happens is that in older men, their sleep apnea severity increases by 3-fold, suggesting that fluid it can be a cause of the sleep apnea. And this is quite important in post-operative patients because post-operative sleep apnea significantly increases the health risks in this population, and they're doing a lot of fluid loading to control blood pressure during surgery. So that's one of the applications of this study. On the other hand, we showed that if you try to reduce fluid retention in the leg and reduce this nocturnal fluid shift, we can improve sleep apnea. We did different studies like to reduce fluid retention, such as diuretics in hypertensive patients, wearing compression stockings during the day to prevent fluid retention in the legs, or exercise like walking to activate the calf muscles, as well as dialysis and ultrafiltration in patients with end-stage renal disease. And we showed that in all these studies, we could improve sleep apnea by 25 to 40%, depending on the population. So we can think of alternative treatments for sleep apnea. And finally, our team is the first to show that asthma is not all about inflammation and smooth muscles. In fact, in patients with asthma, fluid accumulation in the thorax increases airway narrowing and airway resistance in asthmatics. And in the very recent pilot study, we showed that if the patient with asthma wear compression stockings during the day for 2 weeks, that improves their airway narrowing overnight, as well as their wheezing or asthma symptoms overnight. So we can expand this research to other respiratory disorders beyond the sleep apnea. So now what we're trying to do at the moment is to see, one of the works is to try to develop and commercial a comfortable and convenient device that can monitor fluid volume in different body segments, specifically in the legs. And we're working with Mayan, which is a company in tech that works on textile. For example, developing a socks that can measure fluid retention or edema in the legs. As I mentioned, one of the most common respiratory disorders during sleep is sleep apnea, and it's common in about 10% of the population. But the biggest challenge is that of those who are at risk of sleep apnea, about 85 to 90% of them are not diagnosed. So they don't know that they have sleep apnea. And that's because getting a sleep diagnosis is very hard. They have to go to a sleep lab, spend the night in the sleep lab, and then have about 20 different sensors connected to them. So it's not convenient, it's expensive, it causes a long waiting list. And then at the end, if they don't get a good sleep, then they don't know if they have sleep apnea or not. So one of the very nice studies that was done at Toronto Rehab and the sleep team was to try to solve this problem of the diagnosis and underdiagnosis of sleep apnea. And that's a research that was basically led by Hisham Al-Shire and Dr. Bradley, Dr. Al-Shire and Dr. Bradley, and also Dr. Fernie. So what they did was to develop a system, and here you can see the first generation of the system, that records the sound of breathing with a microphone, which is implemented here in front of the mouth. It will be put in front of the mouth, and by looking at the sounds of breathing, detect the sleep apnea. And then over the years, it changed and evolved into such a nice device that we all know as Brezo DX. So the technology in terms of the basics is the same. There's a microphone built in here, but there's no wire. All the electronics are here, and it can be easily used over multiple nights by the same patient. And we have done several studies in different patient populations, and in more than 500 patients showed that the accuracy of the Brezo DX is as good as the accuracy of a full polysomnography. So this is the sleep apnea severity based on the Brezo DX, and the horizontal axis is the sleep apnea severity based on a simultaneous sleep study in the lab. And you can see there is a very high correlation between the two. And because of the work, they received the UHN Inventor of the Year Award 2 years ago, which is very well deserved. Now, what we're trying to do in collaboration with Brezo Tech is to expand on the capacities of this technology and to develop and commercialize a convenient wearable technology that not only can diagnose sleep apnea, but also its consequences. So the patch, or the device that you could see here, has a microphone which can record breathing sound, because now it's over the trachea and easily can record breathing sound. It also records heart sound because we are very close to the carotid artery. And there's an accelerometer that can monitor the position as well as the movement. So in terms of the sleep apnea and the sleep problems, what we expect the patch to do, and we're going to show some results, is to be able to detect how much time the patient was asleep or awake, what was the body posture, what is the sleep apnea severity in terms of apnea and hypopnea index, or the number of the collapses of the pharynx during the sleep, the snoring and the snoring index, heart rate, and an estimate of the airflow. And this technology, or the patch, is actually based on another research that I've done during my PhD, and Dr. Bradley mentioned that. And that shows how it looked like in the past. So we were recording the sound of breathing with a microphone over the neck, We were recording the level of oxygen in the blood with the pulse oximeter. And then with these two signals, we showed that the predicted sleep apnea severity has a high correlation with the gold standard or polysomnography-based sleep apnea severity in about 70 patients who had a sleep apnea. So one of the very nice things that happened throughout my career was that Tech actually licensed this technology from University of Manitoba, and the research that was done in the past is now sort of being alive through the Tech and becoming into the market hopefully in the near future. So here I'm just going to show you examples of the data or the sounds that we can record with the patch. So this is an example of the sound recorded during the sleep. These are normal breathing. Here the subject is snoring, again snoring here, and we have different types of snoring. So here you have an inspiration that starts with normal breathing and with snoring after that, and then followed by expiration here. And this one, the snoring is very severe. So from the almost very beginning of the inspiration, the subject is snoring, followed by expiration. And this one is a normal inspiration, and these are heart sounds. So if you go more in depth, what you see is that these two heart sounds, or those two clicks, are actually your first and second heart sound. So what you can do is to look at the heart sounds to find heart rate, to look at the intensity of the sounds, to have an estimate of or measure of the function of the different valves or the heart in general. And you can look at different snoring. So although snoring is always thought of being just a nuisance and a problem for the subject or the bed partner, we can get information about the shape of the snoring and how that can give us data about the amount of narrowing in the pharynx, because definitely this snore is different from this one. So we are trying to continue the work and develop a strong or robust algorithm to detect the sleep apnea. And because the current guideline is that every device should have a pulse oximeter to detect the sleep apnea, we're developing an algorithm based on both with and without pulse oximeter. So this is an example of the data. So the first two columns are from the gold standard polysomnography. Here is the chest and abdominal movement, the movement of the two of them together. And you see here is normal, this is inspiration, expiration, and when the subject is going to hypopnea or partial collapse of the airway, the amplitude of these movements reduced, suggesting less air getting into the lung. And this is the nasal airflow that you can measure the airflow through the nose, and you see the same thing. Here you have nice inspiration, and then at this period of hypopnea, the level of the air getting into the lung is considerably reduced. And that is associated with a drop of about 8% in the pulse, the level of oxygen in the blood, from 91 to about 86%. And when we look at the sounds, what we see is that we actually see these changes in the sound too. So here you have normal breathing, some snorings here, but in general you have normal. And when you look at this area, then there's the level of the breathing or the energy of the sound is considerably reduced. And that's how we use this to detect a sleep apnea severity. And in pilot studies in 21 subjects who attended the sleep lab here, we showed that the sleep apnea severity based on the patch has a high correlation of 0.97 to the sleep apnea severity based on the gold standard polysomnography. We also tried to see what happens if we try to detect the sleep apnea without pulse oximetry, because now the device becomes much simpler. You don't need a finger probe to measure oximetry. And so again, the same similar signal that you see that the sound amplitude is considerably reduced during a partial collapse of the airway. And we do also look at the accelerometer, because I told you that we have the accelerometer in the patch that can monitor the movement of the tissue of the skin due to the respiration. And we see that there is a reduction in the level of the movement when there is a hypopnea. So by combining these two signals from the sound and accelerometer in different direction, we can detect sleep apnea or partial and complete collapses of the airway. And again, our pilot study is showing that we have a high correlation of about 0.9 in detecting sleep apnea severity, even when we don't have the pulse oximetry. So the accuracy is less than the condition that we do have the pulse oximetry, but still it is quite good. We're trying to get as much information as we could from the sounds that we are recording, and one of them is a snoring sound, because there are different types of snores, there are different levels of snoring, which are associated with different severities of narrowing in the airway, depends on the type of the vibration. For example, we showed that the higher the intensity of the snoring, it shows more narrowing in the airway. Or the lower the frequency of the snoring, it shows that the length of the airway is longer, which can be a risk factor for patients with sleep apnea. So we're working on developing better algorithms to detect the snoring and also to try to get as much information that we can from the snoring sound. Similarly, although everyone thinks that heart sounds are sort of a noise when you look at the breath sound, so if you go to a respirologist and they want to listen to your heart sound, they ask you to stop breathing, or vice versa, they try to stop one to look at the other one. We try to look at the heart sounds to see what we can get from the cardiovascular function or the cardiac function in general. And so this is an example of how we can extract heart sounds in the data which is recorded throughout the sleep. So this is an ECG recorded from the polysomnography, the very nice ECG that everyone can see. And this is a sample of tracheal sound which is recorded. So here we filtered the breath sound, and that's why you don't see the breath here. This is the first and second heart sound. But when you have a snoring, there's a problem. You don't see any heart sounds in these cases. So what we have done was to develop algorithms to really take care of the snore, remove the effect of snoring, and being able to detect heart sounds even in the presence of snoring that can mask the heart sounds. And what we've shown so far is that we have a high accuracy of about, with the error of about 2 to 3 beats per minute to detect heart sounds or heart rate from the heart sounds compared to the gold standard. And these results are basically don't depend on the sleep stage or the posture, so we can detect heart rate with high accuracy. And now we're looking in more depth of how heart sounds can give us information about the changes that happen.
Your entry is not valid.
They told me to laugh at you when you said that. To how we can use that information from the heart sound and heart rate to assess the potential cardiovascular risks of sleep apnea. We're still using the same device, the patch, to find how much time the patient spends sleeping, and that is based on looking at the accelerometer. And so far, we have a high accuracy but quite low specificity, so we can say when the patient is asleep, but there are many times that the subject is awake and we think they're asleep because they're just quiet in bed. So we're working on how to improve finding the sleep time from the accelerometer as well as the sound data. We can also find posture if someone is sleeping in their side or in their back. And the reason that that is important is many of the people who have sleep apnea, especially if they're in the mild version of their sleep apnea, have more symptoms when they sleep on their back. So if they can just sleep on their side, their symptoms get better. So when you tell, or a physician tells them about their sleep apnea severity, they need to tell them in what position they have more, or the physician needs to know in what position they have more symptoms. So here, the top graph is showing the results from the patch, like when the patient was supine, when it was in the left or in the right. And this is based on the PSG that the technician marked by going over the videos. And in general, there is a good agreement between the two, except here in this period that the patch says the subject was in supine and the technician says that they were in the right side. And in fact, when we went back to the videos, we realized that this is a part that the technician missed because it was a short period, and they just assumed that the whole period was right. So we claim that our patch will probably be more accurate in detecting sleep apnea, not because of better finding the posture, but also because of all the other features that the patch or the portable monitoring can add to the sleep diagnosis, like monitoring over different nights, monitoring different outcomes, giving all these extra information on the snoring. So we hope that we really surface and go beyond the PSG as the gold standard with the research we're doing at the sleep team here. The other thing that we're trying to get from the sounds is to have an estimate of the amount of the airflow, because at the end of the day, what matters is how much air gets into the lung through the nose. And the gold standard, or one of the gold standards at the moment that is being practiced, even if it's not the most accurate one, is the nasal pressure. So there's basically putting a nasal cannula and then measure the pressure difference to have an estimate of the airflow. So this is inspiration, this is expiration. And if you compare here, there is less airflow going into the lung or going through the nose compared to here. And when we look at the sounds, we will see the same pattern, that the sound intensity is changing with the amplitude or the amount of the airflow. So when there is less airflow, there is less sound. And that's what we're using. We're basically looking at the sound energy to detect the amount of the airflow. So this is what we estimated based on the sound energy. We can detect inspiration versus expiration, and these are just two different methods. And they nicely follow these changes into the amount or the amplitude of the airflow. So we can think of replacing an inconvenient nasal cannula with something which is much easier. And that is more important if you think of monitoring airflow throughout the long period of time, like multiple months. This is another example that the airflow is going really low. The sound is not as good. We have sort of a background noise, and we need to work more because we are missing part of the inspiration and expiration, showing that we still need to work on this part of the algorithm. Beyond focusing on the sleep apnea, we're trying to look at the other aspects of the sleep apnea and also the factors that contribute to this breathing disorders during the sleep. For example, as I mentioned, we show that we have a good accuracy in detecting body movement, which is very important during exercise. So we're trying to develop algorithms to monitor exercise capacity because we know the subject's movement, we also know their respiratory function, and we can have some measures of their cardiac function, so we can try to develop algorithms to see what exercise is the optimal exercise for each patient. And that's the work that we're doing closely with the cardiac rehab at the Ramsey. We're trying to develop models of the pharyngeal airway, both physical models and acoustic models, to get more information from the physiology of the airway narrowing. We're trying to use the information, for example, from the heart sound to predict the risk of sleep apnea, such as cardiovascular disorders or excessive daytime sleepiness, like what is the chance of these people to have higher or like more drowsy while driving? Can you predict that? And that's the work that we're doing in collaboration with Dr. Kashavars and the driver lab in the field. The other challenge is, can we use this information to predict the optimum treatments for sleep apnea? So instead of going into the try this device first, if it doesn't work, now try the second one, now try the third one, to say which patient may respond to what sort of treatment. And at the moment, we're working with an oral surgeon to see if we can predict the effectiveness of oral appliances, which is another common treatment for sleep apnea. We're also trying to look at other ways of monitoring the sleep apnea for other applications. For example, if you want to monitor sleep apnea for a month, you don't want to connect something to the subjects or a patch or anything because they don't like it. Or if you're looking in the children or patients with dementia, you don't want any sort of contact because that's another burden on them. So with Dr. Taati, we're trying to look at at non-contact monitoring for detecting sleep apnea to see if we can expand the capacities of our monitoring in different populations. So to put all of these together, we're trying to move out from like one solution fits everyone and try to have a range of options, both in terms of monitoring and also treatment. And finally, in terms of what we can do to improve the personalized treatments for better management of respiratory disorders during sleep. So as I mentioned at the beginning, one of the mechanisms that we are working and we believe contributes to the sleep apnea severity is fluid retention in the leg. So if we can reduce that fluid retention, we can improve sleep apnea, as we showed in different clinical populations. And to do that, there are different ways. Subjects can wear compression stockings, so that prevents fluid retention in the leg because it increases the pressure. They can go for exercise like walking, jogging, and that activates the calf muscles. But these solutions are limited to the population. Like if someone has mobility impairment, they can't walk easily. Or if they're spending a lot of time sitting, like a truck driver or pilots, they have or if you're in a long flight, you have limited amount of movement that you can do. Compression stocking can be hard for some people to wear. So what we're working on with Dr. Popovich is if we can develop devices based on electrical stimulation to actually activate the calf muscles through the surface and reduce fluid retention in the leg. So what we showed, and what we ran in one study, was to have the subjects who have mild sleep apnea to come to the lab, and then this was a randomized study. They sat for about 2.5 hours, and we either activated their calf muscles with electrical stimulation, or the level of the stimulation was so small that they just felt some tingling but no muscle contraction. And then they lie down for 60 minutes to see what happens to all these fluid shifts. And what we found was that basically, after electrical stimulation, there was less fluid retention in the leg. And when we look at the main outcome, or what happens to the neck, here the dark bars are showing the sham electrical stimulation, and the light bars are showing the active electrical stimulation. So after active electrical stimulation, there was less fluid accumulation in the neck, either after immediate change in posture from upright to supine, or after lying down for 60 minutes. And when you look at the change in neck circumference from beginning to the end of lying supine, the change in neck circumference after active electrical stimulation was about 1/3 of after sham electrical stimulation. So we really reduced this fluid accumulation in the neck by acute contraction of the calf muscles. And in this population, they were the Brezo DX overnight. And although it was only 1 day of electrical stimulation, their sleep apnea didn't get better, but their snoring reduced by about 15%. So that could be a proof of concept that we can use this in a longer period, like a month, and see if that can be another treatment for people with sleep apnea. And the beauty of that can be applied to any of those disorders, either sleep apnea or asthma, is that, first of all, the compliance is higher. It's easier for the people to wear something like that rather than taking their bronchodilators or CPAP. And it can be even added on top of their other treatments. So they can do this during the day and then have their other treatments to have a better outcome at the end. So we were quite lucky at the sleep team to get a grant from the Canada Foundation for Innovation to develop a new research laboratory at the sleep lab in the 12th floor that you've probably seen part of its construction. And it's called SleepDB, or the Soundproof Laboratory to Examine Sleep Disordered Breathing. So this is the first laboratory in the world that can monitor sleep function, lung function, and cardiovascular function. And at the same time, the whole thing is built into a soundproof lab, so we can develop all these acoustic technologies to not only have a better understanding of the airway physiology during sleep, but to hope to replace those gold standard with convenient devices for better monitoring and treatment. And that will get into my collaborator, that there was no way to do any of the research without the strong support of our collaborators throughout the North America, and also funding from different resources. Thank you.
Thank you very much, Azadeh, for that fantastic overview of all the activities going on in the sleep laboratory. So were there any questions or comments from the audience? Yes.
Hi, Puya from the research team, from a research student. I was just curious, fluid retention and like fluid volume was a key point you sort of highlighted, both in terms of a thing that could cause these respiratory conditions and also the focus on the treatment. I was just wondering if dietary causes, especially the salt intake and carbohydrate intake, is another factor that could cause fluid retention, and if so, are there treatments kind of going into that direction?
Sure. So just to repeat the question, Puya is asking that we talked about all the fluid retention and its effect, and how we're looking into that both in terms of the mechanism of airway narrowing and also for treatment of the airway disorders, and whether other factors such as diet like salt intake can contribute to the fluid retention, and if there's any mechanism to control for that. So that's absolutely correct. I mean, the salt intake can contribute a lot into the fluid retention, and one of the treatments, especially in those who are very highly fluid overloaded, is to control their salt intake. And in all our studies that we're doing, we also control for the amount of the salt that the subjects are taking as a confounder. So diet contributes a lot into that. Sure.
Yeah, that's a very good question. So in patients with congestive heart failure, so that's fluid retention, that water ends up in the lungs and they end up in the hospital with shortness of breath, and they could die from it. One of the main factors contributing to that is high salt intake. So we've actually shown that there's a very strong relationship between salt intake measured by a PhD dietitian and the severity of sleep apnea. So yes, salt could be a target.
Do you have any questions from the remote? Okay. Other questions? Yes, Jeff.
Can you tell us more about how you're going to correlate or how you're going to investigate the changes in shape of the airway under these different conditions? Because in the acoustic laboratory, you're going to have elastography, you're going to have ultrasound. What process do you think you're going to go through?
So the question is how we're going to correlate the changes in the shape of the airway with the different tools that we have. So what we are going to do is basically we're trying to develop models of the airway, like for example have a physical model of the airway and see if we apply pressure, like different levels of edema around the pharynx, how the airway is going to collapse. Is it like uniform throughout the airway? Is it going to be some choke points that is going to narrow more? And what happens? And also do sort of simulations based on the sounds that we're getting. At the same time, so these are all sort of modeling that we're trying to do to better understand. What we're trying to do on the other end is actually to do the measurements as you mentioned. So one of them is what we have at the laboratory is a catheter that has multiple pressure sensors around in like about every 2.5 centimeter. So if you put the catheter, we don't get the shape of the airway, but we get a sense of the pressure changes across the airway, say from the pharynx or the glottis to the level of the nasal cavity. And by comparing the different changes, you can see where the pressure is reduce or how they are changing in compared to if there's going to be a continuous narrowing or some choke points. And that can help us in terms of the site of the collapse. We could look at the elastography. We can't get a shape of the airway based on the ultrasound, but we can try to see if we can look at the stiffness of the tongue and if that is different in patients with a sleep apnea, so more of the amount of the tissue. The other thing can be look at the amount of the edema or fluid in like the main veins in the pharynx and how they can be contributing to the shape of the airway. Unfortunately, we can't really see the airway unless we do endoscopy and then put a camera into that. I don't know if that answered your question.
I was asking on behalf of a very silent
Good.
room.
Thanks.
Because everything is so crystal clear.
So that's the problem on me. Some questions? Come on, don't be that shy. Sure, Dan.
You know, a classic one that everyone likes to ask, and I'm surprised hasn't been asked, is why don't we tilt the bed so that the fluid doesn't reach the neck?
That's actually a really good. So the question is, sorry, I remember to repeat the question. So the question that Dan asked is, why don't you tilt the bed so that the fluid doesn't reach to the neck? So that is actually a very good solution, and many of the patients who have extreme levels of narrowing in the airway, like those with congestive heart failure or chronic obstructive lung disease, they can never ever sleep lying flat, and they have to raise their head to be able to sleep. And that not only reduces the fluid moving to the upper body, but also helps to increase the lung volume and improve or reduce the narrowing of the airway. So that could be actually a very nice project to try to find how severe the sleep apnea is throughout the night and raise the bed automatically. So that might be something that Jeff or you in the room might be interested in, background in biomechanics for adaptive change of the bed posture for sleep improvement.
I've done this highly scientific study of all of my relatives who've had snoring problems at different times, and I've always stuck two 2x4s on their side under the two top legs of the bed. And it's remarkable, statistically, how significant the result is, or at least it's remarkable acoustically in the building, how good the result is, except you've got to go around once every few days and push the mattress uphill.
So just sort of is putting all of us out of business by this remarkable and simple but very effective solution of raising the bed. And I'm sure that many of you, I mean, I had a period that I was coughing so bad, and my only solution was to sleep almost upright to reduce the coughing. So that's very common in patients, and that can be a very simple therapy like position therapy. Yes?
The only concern with that is it might put more pressure on the sacrum, so for patients that are, or the coccyx, so patients that are prone to pressure ulcers might not, they might breathe better, but then have a pressure ulcer.
So I leave that to Dr. Bradley to answer. Please repeat the question.
The question was, if you raise the head of the bed, you might actually put more pressure on the coccyx and therefore give rise to more pressure ulcers. Ordinarily, there's two ways to do that. The first way is to do it by having the whole bed tilt, in which case there would not be extra pressure on the coccyx. But most people don't have beds like that in their homes. So what they usually do is they use extra pillows to raise the head of the bed, in which case, yes, you could get more pressure on your coccyx. However, usually the people who it's been known for 100 years that raising the head of the bed relieves dyspnea in patients with congestive heart failure, because obviously their problem is having water in the lungs, and by raising the head of the bed, it's well known that you reduce the amount of water in the lungs. So that's been known for over 100 years, so this is nothing new. What's new is the idea that that might also contribute to reducing the severity of sleep apnea. That's new. But you're right, obviously sitting up, people don't sit upright to sleep because it's not very comfortable, because you put pressure on a particular spot and that's going to give pressure ulcers. So we're going to have to come up with a way of tilting the whole bed Like Jeff said, you can do that by raising it with the 2x4s or 4x4s, whatever it is you like. But there's probably more elegant ways of doing that, and I'm sure that Ozzy and her team will come up with some brilliant solutions.
So there's still some room for us to do,
There's more than 2x4s.
just a little more. than
Actually, 2x4s built Canada.
Which section of Home Depot?
Canadian Tire.
Any questions?
Okay.
Thank you so much.